This is the third part of the lecture on chapters 18 and 37, and actually we're now into chapter 37. We're going to take a look at brain injury and stroke. There's a fair amount of information in chapter 37, and I may just jump over to the e-text of the book and point out a couple of things there in just a moment. But before we get started, I wanted to be sure on a quick review topic. In order to understand, particularly we're going to look at hematomas and damage to the brain, you have to remember or be reviewed on the cranial meninges and spaces. So I just put this slide up here so that you would understand what those are kind of as a review. So starting superficial or from the outside, if we're going from we pull back the bone of the skull, we come to the dura mater. Underneath, that's the tough outer layer of the meninges, the outermost of the meninges. Under that is the subdural space, which contains interstitial fluid. Below that is the arachnoid mater, and then that's the next layer. It's a much thinner layer, and below that is the subarachnoid space, which contains the cerebral spinal fluid. And then the pia mater is the very thin innermost layer that lays over the brain tissue itself. Worth noting what I have there on the little note, under normal conditions there is no epidural space. The space between the skull and the dura mater is usually fused together. However, there can be injury and bleeding that can actually cause an blood accumulation in this space, separating the dura mater from the skull itself, and therefore space forms in there. So it's a potential space as opposed to an actual space that we list when going through the meninges. All right, so what I'm going to do is take you through a few things on mechanisms of brain injury. These mechanisms begin right at the beginning of chapter 37 on page 927. This is just kind of some background information. It's not really review, although some of the terminology is. So I wanted to kind of have you take a look at it. Focus primarily here on the actual PowerPoint and the notes you're taking here. I'll jump to the textbook in a moment so you can at least take a look at what's there in the book. But the focus is really on what I'm saying here. I'm trying to pull out just a very brief bit of information from what's there in the textbook. So, mechanisms for brain injury, we're saying in the case of things like stroke, trauma, infections, degenerative processes, in these injuries, what actually is causing the problem? That's what I mean by mechanism. So the true cause is going to be you had a stroke, there is trauma, there's a tumor growing in there, but what do those things do to the brain? There's only a certain amount of things that can go wrong in the brain because of the presence of these things or because of the occurrence of these things. So the first one is hypoxia. You should already be quite familiar with hypoxia. So what kinds of things cause hypoxia in the brain? Things like carbon monoxide poisoning. So if you breathe in carbon monoxide, it actually leads to hypoxia in the brain. Carbon monoxide loves to bind at the site of oxygen, not carbon dioxide, carbon monoxide. It binds right where oxygen ought to bind. In fact, our hemoglobin would prefer to bind to carbon monoxide versus oxygen, and therefore that is why it leads to hypoxia in the brain and eventually death. High altitudes can cause this. Severe anemia, where we don't have enough hemoglobin or enough red blood cells to carry the oxygen. COPD is another cause of hypoxia, and we haven't done the respiratory system yet. COPD is chronic obstructive pulmonary disease. COPD, so we'll do more with that when we do respiratory, but we're basically saying lung issues, anything going on with the lungs. That's emphysema, asthma, things of that nature. The manifestations of hypoxia, you should have some sense of that already. We've talked about hypoxia in terms of what's going on in the brain. If it is less severe, and less severe if it's chronic and neurons can compensate a bit, they can undergo anaerobic metabolism, unlike cardiac tissue, which cannot. If the manifestation or if the hypoxia itself is not that severe, in other words, it's not widespread, but rather we almost call it more of a, we're going to probably bring that more almost towards ischemia, but again, this is low oxygen as opposed to no oxygen with hypoxia. You can see some compensation, and so you'll see, as terms of manifestations, some drowsiness, impaired problem solving, some listlessness. However, if it's a more sudden, severe hypoxia, and actually the term for severe hypoxia is anoxia, A-N-O-X-I-A. Anoxia, it's more serious and often is linked to things like cardiac arrest or myocardial infarction. In that case, you'll have unconsciousness or convulsions that eventually lead to unconsciousness. So those are manifestations of hypoxia in the brain specifically. Less severe hypoxia, not completely shutting it off. It's more chronic, and neurons can compensate a bit. You have the drowsiness, listlessness, sudden or severe hypoxia or anoxia, unconsciousness, and convulsions. Another mechanism is ischemia. Ischemia can be either focal. By focal, we mean that it's at a particular vessel. So in that sense, we're talking about stroke. Or it can be global. That is, in blood flow is inadequate for the entire brain. That's something we'd see, for instance, in cardiac arrest. The actual depletion of energy that results from ischemia is really no different than what we saw with hypoxia. So ischemia leads to hypoxia. Okay? So with ischemia, we have several things that you should already understand. We certainly will have mitochondrial injury. We can have disruption in calcium homeostasis. Calcium can start to move into the cell, and that kind of goes to some of the other mechanisms they can develop off of ischemia. Free radical formation can start to occur in cases of ischemia, and we can also activate apoptosis pathways with ischemia, particularly, again, we're dealing within the brain. Remember, apoptosis is programmed cell death. It can come internal and external, and so lack of blood flow can lead to that external trigger and cells start killing themselves. All right, another mechanism is what we call excitatory amino acid injury, and this is where I want to jump to the textbook for a second, so bear with me. I'm going to escape from the PowerPoint and see if I can effectively open up the book. This is page, looks like 929 in your textbook, and it goes to, this is where that excitatory amino acid injury is listed. It gets a little complicated. I'm not asking you to know the steps. I want you simply to recognize the mechanism itself. There are proteins or amino acids called glutamate, and there are receptors in the body for glutamate, in the brain, sorry, not just body, but in the brain. And this is what this figures 37.2 or -2 is showing, is that glutamate receptor. What happens is, in excitatory amino acid injury, certain disorders can cause that, and there are excessive catecholamines and free radicals. All of these can be occurring that can lead to this excitatory injury. The glutamate receptors are overstimulated, so there's the receptor in a cell membrane. It becomes overstimulated, and it opens calcium channels and increases calcium influx into the cells. And this is what I want you to note here. So I'm not asking you to get through all of this process, but note what can happen. It's a mechanism of injury to the brain. These receptors get overstimulated. Glutamate receptors get overstimulated. They cause an influx or an increase in intracellular calcium. The book refers to it as a calcium cascade, but here's all the things that happen if you have an influx of calcium into the brain cells. Release of intracellular enzymes. That's going to start to, again, calcium triggers those enzymes. You're going to use up ATP because you're going to use up the ATPase. They'll cause protein breakdown, free radical formation. You know what free radicals do. Lipid peroxidation, meaning that's one of the damages of free radicals, so it's going to damage the lipid membranes, both intracellular membranes, things surrounding organelles in the cells, like the mitochondria and the Golgi apparatus, anything that's membrane bound. It's going to fragment the DNA, break down the nucleus. That leads to brain cell injury and death. So again, what I want you to understand is when you see the term excitatory amino acid injury, this is what we're talking about. Glutamate is the primary amino acid we're dealing with, and the problem is intracellular calcium. Okay, so take a look at that. Again, you read through it. It's not a very long section to take a look at it to make a little more sense of it, but notice it's linked to things like Huntington's, which we've already talked about, and Alzheimer's, which we'll talk about before the course is over with. So, and the idea that intracellular calcium can be a huge problem here should not be completely foreign to you. All right, so that's one of those mechanisms. Going back, the other mechanism that we're dealing with is cerebral edema, and there's two categories of cerebral edema, or fluid around the brain. There's vasogenic, and in vasogenic we're primarily affecting the white matter of the brain. So that's the area of the neurons of the brain that are covered with myelin. So the integrity of the blood-brain barrier is disrupted. It results in increased extracellular fluids that surround the brain cells. This can occur from bleeding, infections, meningitis for instance, and other forms of physical brain injury can lead to vasogenic, or that form of cerebral edema where you have increased extracellular fluids. The manifestations can be anything from some local deficits in certain areas being damaged to unconsciousness, and severe, what we call intracranial hypertension, increased blood volume, or fluid levels rather, not so much blood but fluid levels, apply pressure on the brain surface. And then cytotoxic edema is an increase in the intracellular fluids. Things like water intoxication, you should remember that from the hyponatremia, one of the main trademark manifestations of hyponatremia. Severe ischemia, we're getting back to hypoxic issues where the sodium-potassium pump fails, can lead to more sodium in the cells because it's not being pumped out because that pump failed, and therefore water moves into the cells. That's going to cause cytotoxic cerebral edema, and the manifestations here will often lead to coma and death. Okay, so these are our main mechanisms of brain injury. And the last thing is what I had mentioned just a minute ago, increased intracranial pressure. It's an increase in the pressure of fluids. It can be cerebral spinal fluid, blood, or extracellular fluid against brain tissue within the confines of the skull. In other words, the skull is the bone, it's whole, and there's only so much room. It doesn't stretch, it doesn't give. And so if the fluid starts to accumulate there, the fluid's pushing against the skull and it's pushing against the brain tissue. And oftentimes one of the ways to deal with that is simply to puncture the skull and allow there to be a release of that fluid and reduce that intracranial pressure. That pressure obstructs blood flow, cerebral blood flow. It destroys brain cells and it destroys the supporting tissue. So increased intracranial pressure is extremely significant. Frequently in our brain injury, this pressure is what leads to death. And so if you can relieve the pressure, you can solve the problem, possibly deal with the blood loss and save the person. All right. That takes us to traumatic brain injury. Now this picture here is straight from the textbook. There's just a couple of terms here, and then we'll look at the types of injury. So just as a note, the terms head injury and traumatic brain injury mean the same thing. So if you have a head injury or you have a traumatic brain injury, for our purposes, they mean the same thing. All right. A primary or direct injury occurs at the time of the injury, and it's going to occur due to direct contact, and that's the coup contusion. And if you see picture A here, coup contusions occur. The force is the red arrow here. This is where the injury occurred. The force hit, say in this condition, in this particular case, the forehead, and in that force hitting the forehead, the tissue that's damaged primarily is the tissue right here. Okay, so that's direct contact or coup contusion. Then you have contra-coup contusions, and there's really, the only difference is the fact that you've got to understand that the brain does have some ability to move a bit within the skull. And in this case, what you have is the head, the injury is at one point on the head as far as the impact, but the actual damage is in an opposite area. So for instance, in letter B, the force hit the back of the head slushed forward, and the injury is actually up here at the forehead. That's a contusion. Likewise, this would be another one. It's on the side, hits on the back left side, and the damage is actually as the brain sloshed forward and hit at the other side. So these are really motions of acceleration and deceleration of the brain. Okay, these kinds of injuries can be local lacerations, contusions. There can be bleeding. A number of things can go on here. Okay, so these are what we would call the primary injuries. This is the force of some impact causes the injury. It's either right at that same spot or opposite the point, but it is a direct or primary injury. It's the injury of force. Okay, now the secondary injury are the processes that develop and lead to cellular injury and death that occur because of the injury at more or less after the fact. So in other words, you have the actual impact, that's a physical damage, and then because of that physical damage, other things can start to develop that can lead to injury. And they can be categorized, first of all, as mild injury, where actually if you looked on a CT scan, you would not notice it. In a mild injury, you can have momentary loss of consciousness, but there will be very little residual damage. Sometimes there's some slight amnesia with a mild injury. Really, with a mild injury, by the way, we're really talking about things like a concussion. Okay, something that happens after we had the physical damage that may or may not have occurred, but then after the fact, how is the brain reacting? What's going on within the brain? And in a mild case, you won't see anything show up really on a CT scan, or nothing significant that shows up. And again, possibly it's loss of consciousness, but it won't last long. But just momentary with no residual damage. Usually recovers within about 24 hours, but symptoms such as a headache, irritability, insomnia, and possibly even amnesia may persist for weeks and possibly months, depending upon the level of mild. Okay? Moderate injury is evidenced on a CT scan. You'll be able to see it. There's usually some small hemorrhaging, so there's some blood loss, and there's some brain swelling. And there is probably some cognitive and motor deficits. Cognitive meaning your thought processes are affected, and any sort of thought. Non-physical is what we're talking about with cognitive. Can include personality and things of that nature. And then there is often motor deficits. That is movement, unable to move an arm, a tingling sensation, a paresthesia, things like that. There may be some palsy that occurs, particularly if, depending upon the area, it may affect the cranial nerves. There may be some hemiparesis, that's paralysis on one side, and aphasia. It may affect some speech as well. And then you have severe injury. This is extensive injury to brain structures. It's often irreversible and leads to coma and death. All right, so we're going to break some of these secondary types of injuries down through what we call the hematomas. So a hematoma is an accumulation of blood between the meninges, or within the brain, or between the brain and the skull. Let me say that definition again. The hematomas are accumulations of blood between the meninges. Remember those? I'll back it up for just a second. We looked at, wrong direction, sorry. The meninges either between the dura mater and the arachnoid mater, or between the arachnoid mater and the pia mater. So they can be between those injuries. They can be within the brain itself. Sorry, I'm going the wrong direction again. So these are your hematomas looked here. It can be within the brain itself, or it can be between the brain and the skull, and that's your epidural. That's the space that normally doesn't exist. So subdurals between the meninges, intracerebrals within the brain tissue itself, and epidural is between the skull and then that dura mater. Okay? So, couple of things to point out. A hematoma can be occurring with as little as 5 milliliters of blood accumulation, so it doesn't have to be huge to be problematic. It can cause damage. All of the hematomas result in pressure on brain tissue, so it pushes against the brain tissue. So that is the problem, is the blood starts accumulating within that area. And often neighboring vessels that may not have been damaged start to vasospasm, which means they contract and relax in an attempt to contain and redirect blood loss. That process, that compensation of vasospasms, often leads to ischemia and further damage. All right, so let's just take a moment to talk briefly about each of the types of epidural or of hematomas. The first one is the epidural hematoma. It's between the skull and the dura mater, and it's most commonly caused by bleeding from an artery or a large vein. So it's a large vessel that's located between the skull and the dura mater. Bleeding often occurs when a skull fracture tears the vessel. So it's actually the damage to the bone, the skull itself, and in that fracture it tears the vessel. It's actually quite common in young people, mainly because the dura mater is not as firmly attached to the skull, so it tends to be more likely to pull away. It's more common in an artery, so the blood accumulation is frequently significant and rapid. An artery's got the blood pressure in it, and so it's pumping a lot of blood through it. In some cases, there is a brief loss of consciousness after the injury. They then regain it and have a period of unimpaired mental function. It's called the lucid interval, lucid, L-U-C-I-D, lucid interval, before consciousness deteriorates again. This is a very important distinction of an epidural hematoma. The injury occurs, they lose consciousness, they come back, and they think they're fine. Oh no, I'm awake, I'm fine, no problem, and they go on about their business, and then all of a sudden consciousness starts to deteriorate again. By the time the consciousness starts to deteriorate again, the blood accumulation tends to be severe, and it's often irreversible and leads to death. And there have been several cases of rather famous people. I can never remember their name when I'm thinking about it, but there have been several famous actors who had Gary Coleman a few years ago just passed away from an epidural hematoma, and the other one is a woman whose name escapes me, but she was married to Liam Neeson, and so if you know who that actor is, and she was the mother in Parent Trap, but I can't think of what her name is now as I'm trying to give this lecture. Sorry, I should write it down. But she was in a skiing accident, and she hit her head and lost consciousness. Awoke, said she's fine, was better. The next thing you know, about an hour or so later, she collapsed and died. So, real important that when someone has any kind of head injury or any sort of loss of consciousness, that they are taken to the hospital, they have the CT scan, the epidural the hematoma would have shown up. You could have helped either bore straight into the brain and relieve the pressure on the brain by removing that blood, and the person oftentimes can live. So therefore, early diagnosis is very crucial, and failure to do so, that intracranial pressure gets very severe, and the person it often leads to death. So that's your epidural hematoma. Subdural hematomas develop in the subdural space. They're more commonly a result of a tear in a very small, what we'd call bridging veins. They're much smaller vessels. The development of a subdural hematoma is much slower than epidural because it's usually involving veins, not arteries. And their subdural hematomas can be categorized as acute, subacute, and chronic. So an acute is where we have a more severe head injury. They do develop rather quickly, so although we said they're slower than an epidural, in an acute case you are going to have a much more rapid response. You will have edema developing, and increased intracranial pressure. And in fact, the results are similar to what you would see in an epidural hematoma, with one difference: you usually do not have that loss of consciousness, come back to the lucid interval, and then go back. In a subdural, in an acute subdural, you may likely have loss of consciousness that does not come back. So it can be just as deadly as an epidural. The difference being that if it's a more traumatic brain injury, it can accumulate rather quickly. Now, in a subacute, there is improvement after the initial injury, and symptoms may develop over days or even weeks. And in fact, if you don't go in and remove the hematoma in time, it can lead to death. So all hematomas can eventually lead to death if they're not dealt with. But in subacute, it's not as much blood, it's not nearly as fast, and so therefore that pressure doesn't go up quickly, and you just see a very slow process. But it's still, in subacute, we're looking at days and weeks before you actually identify it. It's not going to be what we have with chronic. Chronic develops over weeks, and in fact, by the time the symptoms are actually identified, the hematoma could be very large. So chronic's going to take much longer. Subacute, your book listed as days to weeks. I wouldn't put many weeks, maybe a week, 10 days kind of thing for the subacute, but chronic is over numerous weeks. And in fact, chronic subdural hematomas are relatively common in two categories of people: alcoholics and elderly. Alcoholics, because they tend to fall and not remember. They may have injury and just ignore it, and therefore they can develop over time, and their unusual behavior, their loss of memory, their drowsiness, their confusion. If that's an alcoholic, how would you be able to tell the difference? However, in an elderly person, they're more at risk because they too often fall. They're elderly, and their whole cognitive skill levels may be declining. They may not remember they fell either. That might not be all that uncommon for an elderly person to have fallen and not remember it, just in general. Also, as their brain shrinks slightly with age, it stretches those bridging veins more, making them more vulnerable to tears, and there's a little more space between the meninges that can help with the accumulation of blood. So it can go in there and not apply as much pressure, so it can take a lot longer. And in fact, oftentimes you can say, oh, well, grandma's getting she's starting to go a little senile, and lately she hasn't been able to respond correctly, and I guess she's slipping. And people will say that about their grandparent or parent or whatever, not realizing they've fallen, injured the brain, and have this subdural hematoma that's been developing over the last month or two even, maybe even longer. And in fact, their loss of cognitive abilities has nothing to do with their aging, but has to do with a hematoma. So with chronic, you really want to be thinking about what's going on with the elderly. It has actually, subdural hematomas, particularly the chronic and subacute, have about a 50% survival rate. If you get in there and can remove it before things get severe, you can, because you can go in and drain that blood, remove that out of there. It tends to clot and apply pressure, remove it, and you can then continue on with normal function. The brain tissue will recover. All right, and then we've got one more type of hematoma that we're calling a subarachnoid hemorrhage. So although it's a hematoma, we refer to it as a subarachnoid hemorrhage. So we're in the space between the arachnoid membrane and the pia mater. So this is an area that's filled with cerebral spinal fluid, as you'll recall. This is more likely to occur due to an aneurysm. Smokers are more at risk for this. If you have polycystic kidney disease, it's been linked to subarachnoid hemorrhaging. High blood pressure can also, if you have chronic, long-term hypertension, you can be at greater risk for a subarachnoid hemorrhage. In this case, the bleeding is due to tearing of the bridging veins, similar to subdural, although the trauma that causes a subarachnoid hemorrhage is most commonly associated with rupture of cerebral aneurysms. Right? Therefore, there's bleeding is arterial in origin. If it's an aneurysm, it's arterial in origin. You will identify a subarachnoid hemorrhage through a spinal tap because you'll see blood in the cerebral spinal fluid. The symptoms for this include a very severe headache, if the person's even still conscious, and there is ischemia due to secondary vasospasms, and there is clogging of ventricular drainage. So that means that when I say ventricular, I'm talking about the ventricles of the brain. The cerebral spinal fluid is clogged in there. All right, now I also have a picture of an intracerebral hematoma here. I'm not really going through anything specific on that. That's linked much more to tearing of a blood vessel that can occur during a stroke. So we'll hit on that with stroke. All right. That does then take us into CVAs, or cerebral vascular accidents, or stroke. This picture here takes you through, I think they're from your book as well, the pictures on page 946 for cerebral blood flow. It's important that you're familiar with the blood vessels that make up the cerebral arterial circle. You won't have to label them anywhere, but you should recognize that blood enters into the brain. Arterial blood enters the brain through the vertebral arteries that come up through the foramen magnum, and the internal carotids that come up through the carotid canals and enter up into the brain. So you need to be familiar with that blood flow. I'm going to skip this for a second here and go to this table, 37.5. Here you list the major arteries of the brain, what areas receive blood from it, and therefore symptoms that will occur if the stroke occurs there. So you do need to be familiar with this table. You'll see questions on the exam with regards to these four arteries here. Well, it's actually basilar and vertebral are linked together, so technically four categories of arteries. Remember, you have two anterior cerebrals, two middle cerebrals, two posterior cerebrals, one on the left, one on the right side of the brain, feeding the left and right sides of the brain. There's only one basilar, and then the posterior cerebral branches off of that, and there are two vertebrals left and right coming in, and they join together to make the basilar. All right, so please be sure that you spend some time with that. All right, backing up to, we're dealing with CVAs, cerebral vascular accidents. The risk factors for CVAs are basically the same as what they are for all other vascular diseases. You can see them listed in table 37.4, so just take a look at those. We have two main categories of cerebral vascular accidents, or again, CVAs are really strokes. The first one is ischemic strokes, or ischemic CVAs. This is a reduction in blood flow. Usually something is blocking the blood vessel. A thrombus, plaque buildup, forms a thrombus, or an emboli, something circulates through and blocks the vessel. There are some categories of ischemic stroke. The first is listed as transient ischemic attacks. Be very careful with this. A transient ischemic attack, sometimes they refer to as mini strokes. They are not strokes, though. They listed under here as a cerebral vascular accident, but technically they are not a stroke. They are usually occurs due to some sort of little vasospasm or some damage is occurring to the vessel. The risk of stroke increases by 15% within 3 months of a TIA, so it certainly is risky. There may be, at the point at which you have a TIA, there may be some neurological effects that last for a couple of hours, but less than a day. There may be some brain pain, brain angina associated with that. And again, the risk factor increases. The more you have them, the more likely you are at risk for a stroke. But they are not, in fact, strokes. So be careful with that terminology. That's where the book lists them. I left them there. They're not actually strokes, but they are under that category of ischemic vascular accidents. It's not truly an accident yet, but it's a precursor to one. So, the types of ischemic strokes, you have large vessel strokes caused by a thrombus. Usually, atherosclerosis leads to clots, particularly in the bifurcations where the vessels branch, we'll call that term. Most vulnerable is the area where the internal carotid comes in and where the vertebral becomes the basilar. Those are your two greatest areas. Large vessel strokes often affect the cortex with visual defects, aphasia, possibly some transient monocular blindness, meaning blindness in one side. It is most common in the elderly, and it's not associated with activity. So large vessel strokes are not associated with stressful or exercise, or they're not linked to activities. The small vessels or lacunar infarcts are very small. Infarcts refer to deaths of tissue deep in the non-cortical areas of the brain. So we're looking more into the brainstem and deep within the brain. And what happens is with small vessel strokes that as they heal, they leave behind little cavities or lacunas. That's what a lacunar, it's like a space left behind. This can lead to localized deficits, motor hemiplegia. Hemiplegia is partial paralysis, so can't move on one side. Sensory hemiplegia, lack of ability to have sensory input on one side, or what's referred to as clumsy hand syndrome. You can't control the motor function, so it's not completely paralyzed, but the functions are not there. Small vessel or lacunar infarcts are very common in people who suffer from chronic hypertension or diabetes mellitus. Then you have the cardiogenic emboli. This is caused by a moving blood clot. Its most frequent site is the middle cerebral arteries. It tends to have a sudden onset, and that should not say maximum onset, sorry. That should say, if I could cross it out here now, I would. It's maximum deficit. Sorry for the typo there. Sudden onset, maximum deficit. Now careful, this is still blockage of blood flow, but the emboli comes, blocks the vessel, and it's cardiogenic. It's a moving blood clot coming generally off the left side of the heart. Okay? So that's your ischemic stroke. The other type of stroke is hemorrhagic stroke. In hemorrhagic, you have a rupture of a blood vessel. Ischemic, we blocked it. Here, we tear it. The most common risk factors, the older you are and the more you suffer from hypertension, certainly trauma and tumors can also cause this, but the biggest ones would be your age and hypertension. It has a sudden onset, and it is associated with activity. Increased stressful activity can cause the vessel to rupture. It usually starts with a very severe headache. Vomiting is very often occurs with it. Results in edema and extreme compression of brain tissue and vasospasm of the neighboring vessels. So blood starts leaking out over the torn vessel. Starts accumulating, applying pressure on the tissue. The surrounding vessels start spasming, trying to control blood flow, and diminishing blood flow to other areas as well. And certainly, although the symptoms are dependent on the area of the brain, hemorrhagic stroke most often leads to coma and death. It's very rare that people have a hemorrhagic stroke and survive it. There's not a whole lot of minor hemorrhagic strokes. The stroke management, please read through 946, 948 to review how we can manage strokes. That's important to understand. That's a lot of the responsibilities for my nurse majors out there. That's a lot of what you do with these patients is you help find ways. That's your nursing diagnoses to help. You're not going to be able to cure the stroke that occurred, and again, we're dealing primarily with ischemic stroke, but now how do you help them get back to normal function? You most certainly can survive an ischemic stroke, but you need a lot of physical therapy, mental therapy, psychiatric treatments in order to get you over the difficulty of suddenly being paralyzed on one side of your body and trying to regain that strength and use. So please read through the stuff on stroke management. Just it makes for a nice little short answer question for you to address some ways to deal with stroke. We already looked at the cerebral arteries, and I've put some terminology up here that is commonly associated with cerebral vascular accidents. Those that are in purple are the ones I'll put on the exam. Others would be ones you may have seen before. So the ones that are purple, aphasia, This is, issues with language, apraxia, inability to perform purposeful acts, gait apraxia comes up a lot. But again, just what's in purple are the terms. Kind of tried to narrow it down a little bit. So here's some other terms. Just the ones in purple are the ones that you'll be tested on. So other ones you may see in reading and so forth, but the purple ones are the ones that show up on the exam. All right, and that takes you through that unit.